Hi friends, I am Dr. V.V. Rao of Usha Clinic and founder of the websites qmedicaldoubts.blogspot.com and raghavamedicaldoubts.com. Through these videos, I am providing the basic knowledge about the commonly occurring diseases, treatment and surgery details when necessary for the medical knowledge to general people and for reference to medicals. Today I am going to discuss about the urinary diversions. Indications. The chapter explains the ways of diverting the passage of urine when a part of the urinary system is removed from the normal position. The diversion helps the passage of urine to be expelled. Diversion of urine may be either temporary to relieve the distal obstruction or permanent when the bladder is removed. Sphincters of bladder have been damaged or without neurological control. There is an incurable vesicovaginal fistula. If there is an irreversible obstruction and in case of ectopic vesicle. Methods of urinary diversion. Pilostomy, nephrostomy or urethrostomy with indwelling catheters. Cutaneous urethrostomy, suprapubic cystotomy within the dwelling catheter. Cutaneous vesicotomy, cystotomy, suprapubic displacement of the urethra. Uretrosigmoidostomy, in continuity making a recent bladder and colostomy. Trigonocolostomy, in continuity into an isolated conduit. Ureteric transplantation into an isolated ileal or colonic conduct. Procedures. Collection of urine. Catheters. In olden days, indwelling catheters were used for permanent diversion. Side effects. It invariably results in infection and obstruction by phosphatic encrustation. Nowadays, for temporary drainage, the tubes are to be of latex or polyethylene plastic. Bladder drainage. In elderly patients unfit for prostatectomy, an indwelling Foley's catheter changed every 3 weeks is a satisfactory method. Alternatively, St. Peter's Hospital suprapubic drainage apparatus incorporating a straight catheter which the patient or nurse changes daily is acceptable. Cutaneous urethrostomy. Cutaneous stomas, suprapubic vesiculostomy and urethrostomy. Collection from a suprapubic vesicostomy, cystotomy, or from the urethra displaced onto the abdominal wall. For cases of multiple sclerosis in a woman may be unsatisfactory because the local incision causes creases which make it difficult to apply a watertight collecting appliance. Cutaneous ureterostomy. These are liable for strictures in addition, two openings and appliances add to the patient's burden. Mobilization of the ureters and the making of a central abdominal stoma can be successful, but such a degree of mobilization is attended by the high risk of sloughing of the distal ureters due to impairment of blood supply. Ileal or colonic conduit. The most generally useful form of diversion is implant each ureter with a little mobilization as possible into an isolated segment of gut, maybe ileum or colon, which conducts the urine onwards to a cutaneous stoma. Urine is then collected in an ileostomy bag This form of diversion limits infection and avoids the problem of reabsorption of urine as contact time with the mucosa is minimal. Siting of stoma. The site for the stoma must be chosen before operation. The ileostomy bag and the ring are applied to the abdominal wall, and by trial and error the point at which the belt can support the ring and bag at all times and in all positions is found. Checking this by sticking on a bag full of water and asking the patient to perform the type of movement his work will entail. The site of future stoma is marked indelibly on the skin. Colon and rectum. The advantage of diverting urine into the colon is that no collecting apparatus is necessary, and clearly, however, the rectal sphincter must be competent. Before any ureterosigmoidostomy is done, the patient must prove that he can control at least 6 ounces of fluid in the rectum. The disadvantage of the operation is that the renal rectal is exposed continuously to infection from the feces. This can be avoided by establishing a terminal left iliac colostomy and closing the upper rectum to make a rectal bladder. It prevents the urine reflexing retrogradely around the colon to the cecum, diminishes reabsorption and protects renal function. Ureterosigmoidostomy. Stricture formation. In this method, the ureters were cut obliquely and pulled into the gut by a stitch. The ends were not stitched to the gut wall. Stenosis was not uncommon, which can be prevented by anastomosing mucosa to mucosa. Diversion of urine immediately raises the following problems: collection of urine, stricture formation at any anastomosis, and reflex reabsorption of urinary solutes and hence the infection. Reflux of urine and reabsorption of urinary solutes. Reflux of urine. Pressure in the colon can interfere with the drainage and so force air, feces and organisms up to the renal pelvis. Reabsorption of urinary solutes depends upon two factors: reflux of urine round the colon and even into the terminal ileum, and as the colon is acting as a reservoir, the urine is in contact with gut wall for a longer period. Biochemical disturbances are rare if a rectal bladder is made. Biochemical changes associated with the transplantation into the colon are due to combination of reabsorption of chlorides and urea and progressively diminishing tubular function as a result of chronic pyelonephritis. Diarrhea with the loss of potassium containing mucus may exacerbate the loss of potassium. Typical changes are hyperchloremic acidosis with potassium depletion. When severe, the potassium develops loss of appetite, weakness, thirst and diarrhea. It can be prevented by diversion into the ileal or colonic conduit. Treatment. Prevention. The patient is instructed to empty the rectum every 2 hours during day. If acidosis is present, a rectal tube is inserted at night to drain the urine continuously. The patient should avoid added salt in the diet, should take a mixture of potassium citrate and sodium bicarbonate, 2 grams each, at crystals or tablets. A regular biochemical analysis including calcium are required. In established hyperchloremic acidosis, patients should be given suitable doses of sodium bicarbonate intravenously to correct the pH with suitable potassium IV if necessary. Furodantine or ampicillin or appropriate antibiotic should be given to correct pyelonephritis and plan to ileal conduct conversion. Operative procedure: ureterocolic anastomosis. The abdomen is opened by a right lower paramedian incision. The patient is then placed in Trendelenburg position and the right ureter is sought as it courses above the bifurcation of the common iliac artery. An incision is made through the peritoneum overlying the medial side of the ureter, then avoiding the damage to the ureteric vessels, which always approach the duct from outside, and the ureter is identified and dissected from its bed towards its entry to the bladder. The ureter is then divided and its distal stump ligated. The proximal end is trimmed obliquely and split upwards as upwards 1 centimeter. An incision 3 centimeters long is made in the anterior wall of the bowel, and peritoneal and muscular cords are divided but not the mucous membrane. An incision is made into the extreme lower end of the exposed mucous membrane, and the full thickness of the ureteric wall is joined by interrupted 440 chromic catgut sutures to the mucosal opening. The incision in the outer coat of the bowel is approximated over the ureter. Later better anastomosis. Suturing the peritoneal incision around the ureteric implant extraperitonealizes the site, and the drain is left down to the area. The left ureter is implanted into the colon above. In a similar manner, a full-sized Foley's catheter is inserted through the anus no further than the rectal ampulla, and the balloon is inflated. This permits all urine to be measured till the third day. Then the catheter is removed. There must be a full fluid intake. If there is oliguria or anuria, treated accordingly. Ilio-ureterostomy, ileal loop conduit. A coil of ileum nearly 6 to 9 inches long and 1 foot from the ileocecal valve, with its blood supply intact, is isolated. The left ureter is brought through the pelvic mesocolon, and after the ureter has been cut obliquely, end to side anastomosis is performed between the ureter and the intestine. The right ureter is also cut obliquely and joined to the elliptical opening made in the side of the coil. In each case, the anastomosis may be effected by the method of Nesbit. The coil of intestine is tacked lightly to the peritoneum of anterior abdominal wall at the level of pelvic brim. The distal end of the coil is brought out through a stab incision in the right lower abdomen, and due to anchoring of the intestine to peritoneum, the opening is made. Lawley's operation. The rectosigmoid junction is divided completely and its lower end closed. The ureters or the trigone are implanted into the excluded lower segment so that the rectum functions as the bladder. The sigmoid colon is mobilized sufficiently for it to be drawn through the peritoneum immediately anterior to the anus. Thus, both original anal canal and the new anal canal are encompassed by the external sphincter ani muscle. That's all about the urinary diversions, and in the next video I will discuss about some other disease. Thank you.